Welcome back to the podcast. Today, we're talking about fatty liver disease, specifically non-alcoholic fatty liver disease, or NAFLD, a condition that has become increasingly common alongside obesity, type 2 diabetes, and insulin resistance. As described in the article by Hickman and Powell, NAFLD ranges from simple fat accumulation in the liver to more serious stages like steatohepatitis, fibrosis, and even cirrhosis. So, what exactly is NAFLD? NAFLD happens when excess fat builds up in the liver in people who do not consume significant amounts of alcohol. It is often silent. Many patients do not feel sick, do not have obvious symptoms, and only find out something is wrong after routine blood work shows abnormal liver enzymes. That quiet nature is part of what makes NAFLD so important. It can go unnoticed for years while liver damage slowly progresses. Who is most at risk? The major risk factors include overweight and obesity, visceral fat accumulation, type 2 diabetes, insulin resistance, and dyslipidemia, especially high triglycerides. The paper emphasizes that insulin resistance seems to be central to the development of fatty liver disease. In other words, NAFLD is not just a liver condition, it is deeply tied to broader metabolic dysfunction. Diagnosis can be tricky. Patients often have mildly to moderately elevated ALT and AST, but there is no single blood test that definitively diagnoses NAFLD. Clinicians must also rule out other liver diseases such as viral hepatitis, autoimmune disease, Wilson's disease, and hemochromatosis. Ultrasound can support the diagnosis by detecting fatty infiltration, but liver biopsy remains the only way to firmly establish the diagnosis and determine how severe the disease really is. And that severity matters. Not every person with NAFLD will develop advanced disease. Some individuals have simple steatosis and remain relatively stable, but once inflammation and liver cell injury appear, what we call steatohepatitis, the risk increases. The article notes that around 20 to 25% of patients with steatosis plus liver cell injury may progress to cirrhosis. Risk factors for more advanced fibrosis include older age, higher BMI, type 2 diabetes, high ALT, and hypertension. What causes the progression from fat accumulation to liver injury? The authors describe the classic two-hit idea. First, triglycerides accumulate in the liver, likely due to insulin resistance and altered hepatic lipid metabolism. Then comes a second hit, often linked to oxidative stress, inflammation, gut-derived endotoxin, micronutrient deficiency, or mitochondrial injury. This oxidative stress can trigger inflammatory cytokine production, direct cellular damage, and fibrosis. So how is NAFLD treated? At least in this article, there was no established drug therapy. Management focused on controlling the conditions that travel with NAFLD, especially obesity, insulin resistance, diabetes, dyslipidemia, and hypertension. One of the most important recommendations was gradual weight loss, not rapid weight loss. In fact, the paper warns that losing weight too quickly can actually worsen liver injury. Instead, a slow reduction of about 5 to 10% of body weight over 6 months was recommended, because even this amount of weight loss can improve liver enzymes and liver histology. The dietary advice was also practical. Patients were encouraged to reduce overall energy intake, keep dietary fat moderate, choose more monounsaturated fats, and emphasize high fiber, low glycemic index carbohydrates. The article also recommends at least 150 minutes per week of moderately intense exercise, along with more daily movement like taking the stairs instead of the elevator. Importantly, patients should avoid fad diets, excess alcohol, and anything else that may add stress to the liver. One of the strongest messages from the paper is that NAFLD should not be viewed in isolation. It sits within a much larger metabolic picture that includes obesity, diabetes, hypertension, and cardiovascular disease. That makes early recognition especially important. So the takeaway is this: fatty liver disease is common, often silent, strongly tied to insulin resistance, and potentially progressive, but it is also modifiable. Early identification, gradual weight reduction, better diet quality, increased physical activity, and management of associated metabolic conditions remain the foundation of care. Thanks for listening.